Welcome to Raaonline. Today we'll discuss on calcium channel blocker toxicity. So he is Mr. Albert Finkelstein. In 1964, he found out the first compound, the verapamil, that created a status which is equivalent to calcium deficiency in the patient. So he further identified it is because of that it inhibits excitation contraction coupling. So within the next 6 years, this drug was used for hypertension, dysarrhythmias, angina, and further used for Raynaud phenomenon disease, migraine, cluster headaches, and SAH. It is not surprising that this group of CCBs in the next 5 years had 50,000 reported cases of toxicity reported by the American National Poison Data Source. So before going to the CCB toxicity, let us learn this. What is the definition of chronotrope? Chronotrope means increasing the heart rate. Positive chronotrope increases the heart rate. Negative chronotrope decreases the heart rate. Dromotrope is positive dromotrope increases AV node conduction and negative dromotropes decreases AV node conduction. Inotrope is that influences the myocardial contraction. So increase in inotropy means those drugs that increases the myocardial contraction. Decrease in inotrope is decreasing the myocardial contraction. Lucitrope means influences myocardial relaxation. So a drug is increasing lucitrope means it increases the myocardial relaxation. So now coming to calcium channel blockers. Calcium channel blockers belongs to 4 groups. 1. Phenylalkylamine. 2. Benzodiazepine. 3. Dihydropyridines. There was a 4th group which is diaryl aminopropylamines in which mibifradil was a drug. But this had severe toxicity and it is taken out of market. It is no more for clinical use. Though we have 3 different groups, we can divide the CCBs in total as dihydropyridine entity and non-dihydropyridines. So it should be either dihydropyridines and non-dihydropyridines. So these CCBs act either by the voltage gated channels or by the ligand gated channels. This ligand gated channels, the ligand is IP3 or the ryanodine receptor, and these are mostly intracellular. In voltage gated, it could be T or R type or Q type, P type, N type or the L type. The T type is transient, present in the polysynaptic nerve terminals and cardiac neural tissue. The function is going to be pacemaker activity. It's blocked by this mibifradil, which is no longer in use. The R type is in the neural tissue and blocked by the cadmium. Q type again in nerve terminals, blocked by agatoxin, and P for Purkinje, blocked by agatoxin, N for neuronal, blocked by conotoxin. But whatever we prescribe for the patients in our clinical use, everyone belongs to the L type, which is long-acting type that acts over the myocardium and the smooth muscles, causing myocardial contraction. This is the dihydropyrimidines and non-dihydropyrimidine groups. So pharmacokinetics. Once the patient intakes an CCB, it's well absorbed orally. It has low bioavailability because of extensive first-pass metabolism. So in liver, it undergoes oxidative metabolism via the cytochrome enzyme. And whatever little comes out to the blood is also highly protein bound. In toxicokinetics, whenever we say the drug is highly protein bound, it simply means that there is no role for hemodialysis, because hemodialysis cannot remove those compounds which are bound to the proteins. In the liver, like with verapamil undergoes N-demethylation into norverapamil, this is the only toxic metabolite of verapamil. Diltiazem undergoes deacetylation into diacetyl-diltiazem, and all these metabolites are eliminated via the biliary tract. And those that comes to the blood are excreted by the kidneys. So after repeated doses or overdoses, the cytochrome enzyme in the hepatic system can get saturated. So more amount of drug can be delivered to the systemic blood. Thereby the systemic toxicity can increase in repeated dosages or in overdose situations. So now concentrate on this diagram. So this is the heart and there is one muscle fiber which is taken out, the myocardial muscle fiber, and from this muscle fiber there is one cell which has been zoomed up here. Concentrate here. So this is the L type channel. This is the L type long acting channel. So through this the calcium comes inside. Once the calcium comes inside the cell, this sensitizes the ryanodine receptors. So more calcium is released from the sarcoplasmic reticulum into the cell again. So this huge calcium present in the cell, either by the influx and by the efflux from the reticulum, causes direct action of calcium over the muscle fibers, causing muscle contraction. Okay, so when does muscle go for relaxation? These calcium which are present inside the cell after acting upon the muscle fiber need to go back to the sarcoplasmic reticulum. Only if the calcium goes back to the sarcoplasmic reticulum, your muscle can relax. So lusitropy means muscle relaxation. Those drugs that help in this kind of calcium going back into the sarcoplasmic reticulum is called as increased lusitrope. Our usual catecholamines, which we administer to the patient, has both the action. It has the ability to cause calcium influx, calcium efflux from the receptors, thereby enhancing the contraction, and this calcium also enters the sarcoplasmic reticulum by the catecholamines itself. So your catecholamines in use are both good inotropes and good lusitropes. Preferences. So we now have classified the CCBs into two broad categories. One is dihydropyrimidines and other is non-dihydropyrimidines, right? So this dihydropyrimidines prefer less negative membrane potential areas. So myocardial muscle has minus 90 millivolts. Vascular smooth muscles has minus 70 millivolts. It is for this reason that dihydropyrimidines, the amlodipine, nicardia, nifedipine, all these drugs, has direct action on the vascular smooth muscles rather than on the myocardial cells. So dihydropyrimidines act more on the vascular cells, and the non-dihydropyrimidines, the diltiazem, verapamil, acts more on the myocardial cells. So now, in the cardiac muscles, the calcium is responsible for contraction coupling. So CCBs cause decreased inotrophy. In pacemaker cells, the conduction, intracardiac conduction via the SA and AV nodes is by the calcium. If it's blocked, decreased chronotrophy and dromotropy happens. In vasculature, calcium is responsible for maintaining the tone of the vessels. So if blocked, it causes vasodilatation and decreased afterload. Again, in pancreas, calcium helps in release of insulin. If blocked, decreased insulin release happens.